Hello, everybody. Are you able to hear me okay? If you can hear me, please type 1 in the chat box. Thank you. Thank you, everybody. So welcome to our Phoenix Medical Academy first monthly didactic session. And I am very honored to introduce to you our host today is Dr. Leon Nguyen. He is currently a family medicine resident. And we also have our lovely guest speaker, Dr. Samantha Gooch. She is a pediatric resident as well. And she will be here with us for this month and next month to share with us very important topics in pediatrics. And today we are going to talk about pediatric rash and common presentation in the outpatient settings. So I would like to pass the mic to our host today, Dr. Leon Nguyen, to share a few words with everybody.
Hello, everybody. Thank you for coming to my monthly didactics. Thank you, Phoenix and Dr. Christina for sponsoring this event. Really grateful. By no means that this section is for medical advice. This is just for solely traditional education purposes. So a couple of things about Dr. Gooch. She went to University of Massachusetts for biology, and then she go to Alabama College of Osteopathic Medicine for her Doctor of Osteopathic Medicine degree. And she currently a pediatric resident at University of Illinois in Peoria. She have a great interest in child abuse medicines, but she's a wonderful source for pediatrics knowledge that I would like to have her. Thank you, Sam, for agreeing to coming in this month and next month as well. I'll pass the mic to you. So if you have anything to say, introduce yourself.
Hi, everyone. This is the first time I've done a large talk like this, so go easy on me. Also, if you see a cat poking through the screen, just, ignore that. She likes to climb on me sometimes. So I'm trying to share my screen, which I've never done before.
Thank you, Dr. Leon and Dr. Samantha. So what we will have everybody do first to introduce ourselves in the chat box. Your name, whether you're a doctor or a medical student right now, and what city you're from, and your specialty. I think that would be good to know so that we are in this together. And today we want this to be an interactive discussion. So we'll have Dr. Samantha Gooch share her slides and go over the information that she have prepared for us today. And then if anyone has any question, please enter in the chat box. And also, if you think of anything that you want to share, you're welcome to share in the chat box as well. One thing to note that at the end of the session, we will have a survey at the end, an evaluation at the end. And if you complete the survey evaluation for us, we will send you a certificate of completion that you have completed the lecture today. And in the future, we will have a monthly discussion like this for the rest of the year. We have a whole year of session planned out for you guys. So if you want to have this opportunity as a way to improve your medical English, learn new things, meet new people, meet American doctors, then please join us. And this will be very beneficial.
Sorry, so I have to change a setting real quick, so it's going to make me leave the meeting, but I can come right back in.
That's fine. Thank you for letting me know.
Sorry, 1 second.
In this seminar, we will speak in English completely. So this will be an opportunity for everybody to practice listening to English lecture and English medical information. So if you have any question or if there's any part that you're not sure, just continue listening and don't worry. I will have this session recorded and I will post this on YouTube later for you to review if you need to. All right, looks like Dr. Gooch is back.
Are you guys able to see my screen?
Yes.
Okay, perfect. I've just never done that before, so. Okay, so I'm starting off with newborn rashes. And a lot of these I based on the Stanford Medicine link. So if you search Stanford Medicine Newborn Nursery in Google, they have a really great photo library for you to go through and practice these on your own. These are really, a lot of these are very common baby rashes that I see every day. I did a whole month in the nursery. I saw them every day. I saw them as an outpatient clinic seeing newborn exams every day. Like these are just, some of these are just bread and butter. Some of them are more rare. But basically the way I'm going to present it is I'm going to ask, do you think it's normal or abnormal? And what do you think it is? And if you're comfortable speaking English, you can answer. Otherwise, somebody can interpret for you. I wish I spoke another language, but do your best. The point is a lot of learning happens when you get things wrong. So this is a safe way to get things wrong. So just don't be shy. If you think you have an idea, just bring it up. And at worst, we're gonna just have the learning about it. So also disclaimer, I am not a dermatologist. I'm doing my best. I do see a lot of these, but I'm a pediatric resident. I'm ending my first year. So I'm still learning a lot myself. So just go easy on me. I'm doing my best. Okay, so this is our first one. Would anybody like to guess if they think it's normal or abnormal and what they think it might be? And Leon, if somebody answers in the chat, could you just let me know? I don't have the chat open.
Will do.
Thank you.
Everybody, you can just answer in the chat box, or you can just use your mic and speak up. That's totally fine.
Everyone hear me?
Mm-hmm.
Yes.
My name is Vĩnh Anh, so I want to answer this. This is an abnormal kind of rashes.
Okay. Do you think you know what it might be?
It's kind of really severe infection. It's kind of Staphylococcus aureus infection because it has exfoliate skin. The skin is exfoliated. Look at the hand, I can see that.
So what's actually very surprising about this one is it's actually completely normal. This is actually just normal baby peeling. And so if you look at the hand, I knew the hand would throw off some people. So don't feel bad about that. But it's the hand is from a baby that was just recently born. And if you look at the skin and the tissues, it's actually just dyed a little bit yellow because of the meconium in the fluids. And then if you look at the picture on the left, that's just a little bit of dry skin. This typically happens with full-term babies and as well as post-term babies. Sorry, one second. But yeah, so this is actually a completely normal rash, and I'll leave it up for another couple seconds so that you can see it a little bit more. And we see this all the time. We do see this all the time. So this is why I wanted to do it this way. It's a really great way to see, you know, what your initial thought process is, because a core part of pediatrics is knowing when things need to be treated and when not, and when you need to draw labs and when not. We're always trying to draw the minimal labs possible. With adults, I don't think that's quite as much of a priority. We tend to order lots of things and try to figure it out first. With pediatrics, you try to be as minimal as possible. A lot of times with these babies, you can't draw more than about 3 mils of blood. So if you do want labs, you have to be very specific about what you do want, because you can't get more until the next day, because we are at risk of making these babies anemic just from drawing labs. So we definitely don't like to go overboard. So it's a really a big part of pediatrics is just knowing when you need to do more, when you need to do more testing, and when you don't. Okay.
That's a great answer, Linan.
Thanks for sharing. And I think that's so true. Specifically as a mother, when I take my baby to the doctors, and then the doctor decided to do blood, at that point, you know, if you're a doctor, you know that it's gonna be painful and everything like that. But from the point of a mother, then you understand that you don't want your baby to lose blood unnecessarily. So that is really a good point, Dr. Gooch.
Thank you. Sorry, I'm just trying to access my notes for this PowerPoint. All right. And now, do we think this one is normal or abnormal? And what do you think it is? So I'm gonna just do this a little bit differently because I want to be able to see my notes. So this one is an abnormal rash. This is called congenital ichthyosis. And so a key difference between this and the last rash is that this has more redness and inflammation. It has more swelling. If you look at this baby's hand over here, you can see where the fingers look swollen. There's more edema with this. And so this is a lifelong skin condition. This is a problem with the barrier that the skin provides, because one of the biggest functions of the skin is to retain moisture and keep babies hydrated and help moderate skin temperature. And so what happens is these babies lose fluids very quickly. We have to be very careful about their hydration status. This is actually not a rash that I have seen yet, but this was one I really wanted to put in because it really differentiates from that normal baby skin peeling in the last photo to this one. Because that one, it just looks kind of dry. That hand looked a little bit moist, but it was also just a new baby. This will continue to look kind of moist and swollen and inflamed, and it won't look as calm and nice as the first one did. And so these babies tend to need to go to the NICU because they tend to need to go in an isolate, which will help moderate their warmth, their temperature. It keeps them warm. And then you can also increase humidity to keep that moisture in and help keep them hydrated. But throughout their life, they'll have to be particularly careful about emollients, which is like Vaseline, like thick ointments to help provide that barrier that their skin is lacking. And so with these types of babies, you're definitely going to want to involve genetics and a dermatologist specifically to help manage this.
So like, I have a quick question.
Yes.
Is this life-threatening by any chance?
The rash in itself is not life-threatening, but the complications that could arise are. So if you're not properly managing it, you would worry about this baby getting dehydrated or hypothermic or just having a severe infection. Because when the skin can't stay hydrated and provide that essential barrier, then you can definitely open yourself up to worse infections.
Thank you.
Of course. All right. So let's move on to the next one. I'm going to shut this down before I go to the next one. Okay. How about this one? Anyone want to comment on this one?
Yeah. Hello, could you hear me?
I can.
Yeah, okay. I think this is spot Mongolian on newborn baby.
Mm-hmm. So is this something that you think is normal or abnormal then?
Yeah, is it normal? It's totally normal.
Good job, yes. So this is definitely Mongolian spots. We don't use that term anymore just because it's just not a very politically correct term, but we call it congenital dermal melanosis or slate gray patches. Same thing though, you're absolutely correct. It tends to happen more with babies of darker skin tones, but you can still see it in pale skin tones. Sacral area is most common to have them, but you can have them all over. That's why I included this one with the arm, because some of them just look funny in weird spaces and you're just like, is that really normal? And it is. No interventions needed. Sometimes they will disappear throughout their life. Sometimes they stick around, but it's really just a different coloring. Any questions on that?
Yes, just want to clarify that originally this is called Mongolian spot, but in America, we kind of tend to move away from term that's mentioned specific race or countries or where the things originally come from. And that's why we named it congenital dermal melanocytosis. It's a little bit longer, but we kind of avoid saying Mongolian spot, but people are still widely known this as Mongolian spot. But thank you, Dr. Gooch.
And the biggest thing that this gets mistaken for is bruising. So that's why it's a really good thing to just recognize when you see it. But bruising, you'll tend to see the color varies more throughout that spot and does change throughout the day or after a couple days. This one won't really change after a couple days, and the color shouldn't really vary too much throughout the spot.
Yeah. Just want to share a fun fact. My son has one on his the dorsal part of his arm.
Yep, they can look kind of odd because they're not in the usual spots, but yeah, they're completely normal. So what do we think about this one? And all of these images too are on that Stanford newborn nursery picture library. So it's really great. This is great practice. I didn't do all of them. I just did like a lot of the most common ones and ones that I think were important to differentiate. Any thoughts on this one, whether it's normal or abnormal? If you're not sure what it is, that's okay.
Yeah. Dr. Samantha, I think it is abnormal.
Okay.
Yeah, I think it is abnormal because I see a lot of small vesicle. Yeah.
So you got the
bus.
You got the name of it right. It's a salmon patch. Also can be called an angel's kiss, but it is actually completely normal. It's also known as a nevus simplex. It's basically just a birthmark. My fiance has one right in the middle of his forehead. I can particularly see it when he is like exercising or getting upset about something. It flares bright red. So it's just a capillary malformation. It won't have any harm. Usually they do go away or at least fade a lot, particularly the eyelids. So the eyelids is what's called an angel's kiss. And then the forehead can also be called an angel's kiss as well, or a salmon patch. But it's just a type of birthmark, really. So very common. We see this all the time and totally normal. No interventions are needed at all. Any questions on that? Okay, we'll go to the next one. Oops, I showed you the answer for this one, but it's also a salmon patch. So this is just in a different spot. You can kind of see it here at the base of the skull. So this one can also be referred to as a stork bite, mainly because that's just where the stork would theoretically carry the baby. So, but it also is just a salmon patch. It's the exact same thing as the last picture, just in a different spot. Okay, what do we think about this one?
I think this is port-wide stain.
Yes, good job. Is it normal or abnormal?
This is not abnormal.
Good, yes. So this one is abnormal, and the reason why it's abnormal, so the rash itself is not dangerous. It can be harmless. It can just be a rash. But sometimes port wine stains can be associated with other conditions like Sturge-Weber syndrome or Klippel-Trenaunay-Weber syndrome. And I left those names in the chart so you can see them. It kind of depends on where it is. So if it's on the face, you would worry about the Sturge-Weber syndrome on the extremities, Klippel-Trenaunay-Weber syndrome, and then directly on the spine, you'd want to make sure there isn't an occult spina bifida. So some of these just might require some more imaging or genetic workup, or just watching them clinically to make sure they don't develop any issues that would require more lab workup. This one in this image is a completely normal port wine stain. This one didn't require any sort of treatment or interventions. So you can have just a port wine stain and it's not anything else, but it's always good to be aware of possibilities and making sure that we know what we could be looking for. Okay. Okay, how about this one? This one's going to be a little tricky. If you don't do peds, you might not know this one.
I think this is a hypopigmented patch or
Yes.
mercure.
Mm-hmm. Good, very good. So this is a, oh, is it normal or abnormal?
This is normal.
Good.
I think
yes.
this is normal, but sometimes it's we must rule out abnormal. Is like asleep mercure.
Okay, yep, I know what you're talking about. So if you had more than one, you might want to, but so this is just a hypopigmented macule, and what he's looking at is this spot right here. And what you can see right here is actually a little bit of a congenital dermal melanosis. So that Mongolian spot is right there. So it's got more than one problem in it. But it's just an area of vasoconstriction. So it's just a little bit pale there and it will go away. Nothing that needs to be done for this. So that is a completely normal finding. It's a little harder to see sometimes. How about this one?
I think this is milia.
Normal or abnormal?
Normal. I see a lot of them.
Yes. Yes. So it's just some keratin-filled epithelial cysts. So these are really common. We see these on babies all the time. And so sometimes if you see these popping up after 2 weeks of age, commonly in the outpatient clinic, then that would just be neonatal acne. And that's also normal.
Yeah.
But neonatal acne has more of an inflammatory component than milia does. But it's not infectious. It's not really something you really need to treat. Just moisturization is key with a lot of these rashes.
Yeah, fun fact, I saw a lot of moms come in like first week baby newborn check, have this, and they're all concerning that the baby was infected.
Mm-hmm.
So any good advice for them besides like just tell them like, hey, it's gonna be okay, just hydration and
yeah, the biggest thing is just going to be reassurance with these moms, with both the parents really, and that's half the job as a pediatrician, is making sure you know what's normal so that you can reassure them that everything is okay and their baby is perfectly fine, and being able to ring the alarm bells when things are not normal. So with this, we would just use unscented lotion, a baby lotion, or some Vaseline just a few times a day. And most of that is actually just to make the parents feel better, like they're doing something, to be honest, because it will just go away on its own. It doesn't need anything in particular, but something like that is so harmless that it's okay, like, to have them do something to make them feel better. So sometimes you're treating the parents more than you're treating the baby. How about this one?
I think it's normal. Malaria.
Sorry, did you say it was not normal?
I say normal. It's normal. Yeah, malaria. I guess malaria.
Okay, so this one is sebaceous hyperplasia. And this one's a little bit different than the first one. The first one you typically see like spotted all over the face and the cheeks and stuff. This one's just concentrated mostly on the nose. And it's just due to androgen exposure from the mom. So this one we see in a lot of newborn babies. This one's really common as well. And there's nothing that you would do for this either. This will just go away over time, particularly as mom's hormones leave the baby's body. There's a lot of transitioning that happens at that time, actually. Like female babies will have what we call a mini period, where they do have a couple spots of vaginal blood. And that's just from mom's hormones leaving the body. So there's a lot of changes that happen just from mom's hormones. Okay. How about this one?
It's a skin infection. I think it's not normal.
Okay.
No, I think it's normal.
So
I don't remember the name, but I think it's normal.
So one person's saying normal, one person's saying abnormal?
Yes.
Okay. So this one is normal. Let me bring up the notes so everyone can see them too. Okay, so this one is called Erythema toxicorum neonatorum. So Erythema toxica, that's also another name, but it's just a normal baby rash. So you'll typically see these little yellow papules with redness around them. They look like little pimples. And this is the single most common newborn baby rash that we see. They usually start to pop up at around 1 to 2 days of life, and then they go away on their own over the next 1 to 2 weeks. Nobody really knows what causes it, to be honest, but sometimes you'll see them fluctuate in normal in number before they officially go away. So over the next week, they might pop up in new areas and go away in other areas, or increase in number and just look kind of funny. But as long as they still have the same appearance and the baby doesn't have any other symptoms, it's really just the normal erythema toxicum rash. So it's just something that we do see a lot of, though. So this is a good one to be familiar with for peds.
This one is interesting because the name sounds scary, like toxicum, right?
Yes.
And then it looks scary. So I remember always having to explain to parents that this is totally normal. Mm-hmm. It looks scary, but it's normal.
Yeah, that's whenever I talk to parents about this one too, because they'll say, oh, what are all these red spots? And say, well, it's erythema toxicum, which is a big fancy word for normal baby rash. So I always emphasize that it is normal. And this is another one too, where parents can use some lotion or some Vaseline to help with that moisture in the skin if they want to, but it's not required. This will go away on its own without any sort of treatment.
So I have a quick question for you, Dr. Gooch. I see this a lot of the time too, but so how do we know if it's like not infected or not?
So infections with babies are very rare. So all of these erythema toxicum spots should look like this. They should be little papules with redness around them. If you see variation in that, so the number will change. So you can have lots of papules or just a couple. But if you see variation in that, where you're getting like a lot of localized swelling or just any sort of changes in the skin besides those papules, that would be a problem. Also, any sort of fever in the first month of life is an emergency. Especially since there's always the risk that baby could have picked something up from mom, but they just do not have the immune response that we do yet. So any sort of fever within the first month of life, we work up as if it could be like a meningitis. So they get a full CBC, we get a metabolic panel.
Dr. Gooch, I think you kind of mute for a second.
Sorry. Oh, what did you hear?
I think you stopped at metabolic panel.
metabolic panel, blood cultures, urine cultures, and a lumbar puncture. And the reason for that is we don't want to miss an infection with these babies. If it gets to a point where it is turning into like a meningitis picture, it can become too late to treat them very quickly. So when we have a newborn baby, if they develop a fever, we go after it very quickly. So that is very important to recognize. So if you just are seeing these spots, it's just a normal baby rash if everything else is going fine. If they're having any sort of symptoms or they're getting a fever, that's when you're starting to have more, you're going to do more of a workup and probably start them on antibiotics as well immediately. Okay.
Yeah, I think the topic about pediatric, especially infant fevers, is a very important topic.
Mm-hmm. Yeah, infant fevers are very, very, very important. But that's, if nothing else, then just always tell your families, if they notice a fever in the first month of life, they should just go to the emergency room. Okay,
I have a question.
Yes.
So I think this erythema toxicum is exclude diagnosis, because before we diagnose this condition, we must rule out infection first, because we don't want to miss the diagnosis and put the newborn in some danger.
Okay, so I totally understand what you're saying.
Yeah.
So the reason why we wouldn't do that for every baby that we see this rash on is because we see this rash on almost every baby that comes in, that gets delivered. This rash is so common, you would be working up almost every baby that way. But the amount of times that we actually have a true infection is far, 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 far lower. And there is harm that comes with drawing these labs and doing these tests, because those also expose to potential infections in themselves, and antibiotics are not without their own risks as well. But this rash itself usually does not ever turn into an infection. It usually will just go away on its own. Typically, all babies are monitored in the nursery or on the newborn floor for at least a day or two before they go. If they're going to have a maternal complication that would cause a fever, they usually will spike in that first 24 to 48 hours. And if they spike anytime at home, it's usually from like a viral cause, to be honest. We do get newborn fevers and we do the full workup, and it's usually just like a respiratory virus that does it for them. But the association with erythema toxicum and an actual bacterial infection that would require treatment is almost non-existent. So doing a full workup like that for every baby that has this rash would do more harm than good in that sense. It's a very different way of thinking, I think, than with adult medicine, because with peds, everything is a lot more conservative. We do everything to reduce the amount of invasive testing and risk that we can pose to a child, because every blood draw, everything you do can cause trauma.
Yes, I totally agree with Dr. Gooch. I think the American Academy of Pediatric do not recommend a full workup and testing for these babies. Usually these babies on the newborn floor got monitored over days, like 1 to 2 days before they got discharged with their mom. Mm-hmm. And usually if they have anything like fever or anything concerning, we usually caught right at that time. And we do give parents a return precaution about what to expect. So I think the bottom line answer is the overall clinical picture of the child, right. And not just working up everybody as extensively is really not good for the kid at all. So just based on your clinical reasoning, I think is very important as well.
Mm-hmm.
Yeah, I totally agree with that as well. So I think fever is a very big thing that we look for infection. So if the baby is doing well, no fever, then it's very unlikely that it is an infection.
Mm-hmm. And typically if you have an infectious rash, by the time that you have a rash from that, you typically have other symptoms as well. The rash usually isn't the first symptom you see before anything else. So usually the rash comes a couple days after an infection or with the start of other symptoms as well. Okay, so what do we think about this new one?
I think with this picture alone, I think it is a transient neonatal pustular melanosis.
Very good. Normal or abnormal?
It's normal.
Good. Yes, so this is transient neonatal pustular melanosis. You're perfectly correct. So this is an earlier version, particularly if you look here, you can see these little white pustules, and these usually break after 1 to 2 days. And then what's left behind after those little pustules break is these little dark spots that look like freckles all over the baby. It's more common in African-American babies, darker skin tone babies, but it can happen with any race. And this rash actually starts when they're still in the womb. So it starts with these little pustules all over them when they're in the womb. So sometimes they come out and they don't have these pustules anymore. They only have these freckles. Sometimes they come out and they still have the pustules all over them, and then they burst and they leave these little freckles on them. So it kind of depends. Sometimes you see it in different stages. But again, these spots will just disappear over the first couple months of their life. And there's nothing really you need to do for it. There's no real risk of infection here or any abnormality. It's just something that happens for whatever reason. Okay. And what about this one? No takers? Okay, so that's okay. So this is actually just petechiae. So this is abnormal, mostly because there is risk that there could be something else going on here, and this would require some more workup. So when you just see petechiae in a certain area, that can just be from labor and delivery. It's a rough process. It's a very rough process for these babies. So sometimes they just have some petechiae, which are the broken blood vessels under the skin. So if you think about it, that's caused by high pressure usually in those situations. And so you might see spots of petechiae in some places and other places. And what this person's doing here is they're blanching the skin, and you can still see that those red spots are there. So that's a good thing to remember, is that petechiae are non-blanchable. Some of these rashes will blanch when you push on them. Like erythema toxicum, when you push on them, they'll blanch. So they'll pale. They'll go pale. But this will not. You'll still have the red spots left over because it's blood sitting right under the skin. It won't go away just because you push on it. So this one, it can be normal from the process of delivery. But if it's expansive and like all over the body, you might want to consider something else. So it's a good idea to get at least a CBC to make sure they have a normal platelet count. Neonatal Thrombocytopenia is something that can happen. Sometimes that's just due to placental insufficiency or that they're not making enough platelets. But usually the thrombocytopenia doesn't start until more than 72 hours after their birth, or less than 72 hours. If you have petechia starting at more than 72 hours after birth, then you start to worry about infectious causes or sepsis. So petechiae can also be a cause of not a cause of infection, but a worrisome finding for infection. And we also actually, I don't know if every hospital does this, but at our hospital, we check a maternal platelet count, because we've found that sometimes low maternal platelet counts can be associated with low platelet counts in their babies. And so we wouldn't be as surprised to find a low platelet count or petechiae in a baby that came from a mom with a low platelet count. So that's just something to be aware of. I'd say if your CBC is normal and the baby's otherwise doing fine, it's probably just from the process of delivery. They can also get conjunctival hemorrhages, like in their eyes and the whites of their eyes from delivery as well, just because it's such a rough process with a lot of pressure. So a key is, again, like a lot of the big take home for all of this is what's the clinical picture of the baby? Because usually if they're doing fine and there's nothing else wrong, they usually are just fine. Any questions on that one? Okay, so here's our next one. And this is one that I haven't seen in person yet. No takers?
I guess it's abnormal. Maybe hemangioma is abnormal.
It is abnormal. It's an abnormal rash. I couldn't quite make out the name you're giving. I think you're cutting out a little bit, but it is cutis marmorata telangiectasia congenita, CMTC. So that's a big long name. And so what you'll typically see, so we're looking at this patch here, or over here, we're looking over here and here. There's like atrophy of the skin and the tissue underneath it. So you see this kind of like depressed area. It's harder to see here, but you can really see it in this picture, which is why I picked this one to include. And so it's typically associated with hypoplasia of the tissue underneath these markings. It's a congenital vascular malformation. So these are basically just blood vessels that are widened and dilated, flattened, basically. So the rash itself is not really a problem. But about half of kids with these rashes can have other defects as well. So you should always do like a really extensive exam, particularly with these babies. And some things they're more prone to is they might have loss of muscle in another part of the body. They can have glaucoma, or they can have a short leg, undergrowth of one leg. They might have other skin lesions, just some things to watch out for, nothing like imminent or life-threatening. But they typically only affect one limb when you see this rash. So you shouldn't see these spots all over. But yeah, this is one that I have not seen in person yet.
Yes, thank you. I
That's
have
a very
never
good
seen
one.
before.
Mm-hmm. Yeah, no, I still haven't. It's definitely not super common. Okay. How about this? So we're looking at this spot here.
It's very hard to see because it's very blur.
It is.
Anyone see it blur?
It is a little blurry.
It is a little blurry, but I can make a guess.
I don't think I can diagnose this with this picture.
That's okay. So this one,
yeah, I was about to say hemangioma because I saw this.
Yes, because this is the start of a hemangioma. So the rest of the picture is blurry. You can still kind of see this fairly okay. What you're looking at is the telangiectasia in the very middle of it, and then you get the paleness around the outside, the pale ring. And so this will continue to grow a little bit and get a little bit elevated and darker, but they do typically go away. So they don't need any sort of treatment, and doesn't really mean anything when there's only like one. But they can sometimes require surgical treatment just if they're in a bad location. So like if they fall like on the diaper line or like on a very vascular surface like the eyelid, those might be reasons to have it treated, just because it poses a risk for becoming more irritated, can be an infectious source in the future, particularly if it gets injured and exposed to bacteria that way. But typically when you see a newborn, you're only going to see something like this. In the outpatient setting, you'll see the actual formed hemangioma. But yeah, sorry, I know it's early hemangiomas were kind of hard to find a picture of. And that Stanford nursery only had a couple images of it. So that was like the most characteristic one I could find. And how about this?
Hemangioma.
Yes.
It's very typical hemangioma.
Yes. Although these are atypical locations, so you don't typically see them on the feet like this. And this one is very deep, so it doesn't look as dark red as this does. But it's still the same thing. It's still a hemangioma. So this is a type of hemangioma called a congenital hemangioma because it's fully formed at birth. With the one that we saw in the prior picture, that's a typical hemangioma. So it doesn't start getting dark and raised like this until over the course of a few days. So there's different classifications of congenital hemangiomas. Rapidly involuting or non-involuting. The rapidly involuting ones will go away completely on their own. Non-involuting ones will usually shrink, but may not completely go away. They really don't need treatment though, unless they're in a problematic area again. This one did end up completely going away, which is great. But sometimes they do need treatment, which is why I classified it as abnormal. But it's good to reassure parents that it's not like a life-threatening complication, and it's not something that's immediately dangerous. It's mostly just an appearance. Okay. How about this one?
Cafe outline spot, fibromatosis type 1.
Very close.
Every spot.
This is called a junctional melanocytic nevus.
Oh.
So this is basically just your birthmark. And these can vary a little bit in appearance. So sometimes they look dark in the middle with a paler outside. Sometimes they have a darker ring and pale on the inside. But they're typically flat. They can raise a little bit sometimes later in life. But usually if there's just one or two, they're just melanocytic nevus. It's just a birthmark. But I think you know what that one is.
Oh, this is the cafe au lait spot.
Right.
Yeah.
Yes. So this is cafe au lait spot. The thing to remember about cafe au lait spots is if you just have a couple, they're normal. But if you have 6 or more spots that are greater than ½ centimeter, like you said, there's a concern for neurofibromatosis. So if you only have a couple, it's okay. Because typically we do see these a lot. We see both the junctional nevus and we see the cafe au lait spots quite frequently. But typically babies don't have more than 1 or 2. But if you have more than 6, then that would be a reason to be concerned. So you're looking for lots of spots. And this is just an increased amount of melanin and melanocytes and epidermal cells. And this one will typically get darker with age as well. Doesn't usually go away. It's just, again, it's just another type of birthmark. How about this one?
I think it's normal.
Okay, is it because you cheated and looked at the slides already?
No, I saw this sometimes in the office. Yeah, but I don't know what it's called, but I think it's normal. It doesn't look like abnormal.
Yeah, so this is normal. It's actually, in my opinion, one of the cutest newborn rashes. They're called sucking blisters. So it's from when they're in the womb. They will sometimes suck on their wrists or their hands or another part of their arm. So it's just a little bit of a blister that they got from sucking. So the key to this is they are going to be on a surface that is accessible to their mouth. So usually a part of their hand or fingers or arm. And you get these little blisters that will just go away over the next couple of days. So no harm to the baby, but I think it's the cutest rash, if there is such a thing as a cute rash. And how about this?
Skin tag.
Good, yes. So skin tags, these are normal. This one is a little bit, has like a really long stalk. So these ones were actually removed also because of the location. If they're in a location where they're at risk of being torn or they're kind of large, like these ones are a good size, then sometimes it's a good idea to take them off. Sometimes they just use scissors, like surgical scissors, to cut them or tie them off and let them fall off. But they don't have to be removed. They pose no other risk besides just a risk to have them injured if they're in a bad spot. How about this one?
What do we mean? This one is many lesson in here. We see sebaceous, like you said before, and the lip is quite. How
about over here?
Scratch mark. Scratch.
Yes.
Yeah.
So babies tend to just have no comprehension of where their hands are going, and they frequently will scratch themselves. So it's a good idea to have their fingernails trimmed or put a little mitts on their hands. But yes, you're right. You do see the sebaceous hyperplasia here. This is just the typical appearance for a lot of babies' lips, particularly when they're newborns. It's just, there's a lot of like old tissue that's just drying off. So it's not uncommon at all to see lips like this. But yeah, so the main thing was the scratch marks, just because not everyone has peds experience yet, and maybe nobody has seen what those look like. Particularly when you have a newborn baby, having new scratches can be a little alarming. How about this?
Forceps. Forceps mark.
Yep, forceps marks. So this was obviously a complicated delivery if they had to use forceps, and that will again fade and go away over time. And how about this one?
Welcome mark.
Yes,
it's remember me of 3 Idiots, my favorite film. Do you know it?
Say that one more time.
3 Idiots.
No, I don't know.
You don't know that film?
No.
No.
I'm sorry. But yes, this is a vacuum mark. So you can see this red line here from where they had to use a suction cup and help pull them out. One thing I wanted to mention with this is anytime you have a vacuum delivery, you always follow a subgaleal hemorrhage protocol. As I'm sure a lot of you are aware, the subgaleal space is a very large space, and newborns in particular are at high risk of bleeding into that space. But because it's such a large space, they can lose almost their entire blood volume in that one space, so they can bleed out. And really what we do for that protocol is what we'll do is we'll use a marker and we'll mark this line and track the swelling and make sure that the swelling is not getting overly big. It'll get a little bit bigger over the course of a day, but then it should start to recede. So we just keep a close eye on the baby and do frequent vitals and make sure that we don't see any signs that the baby's losing blood. So that's it. Well, what I had for newborn rashes. I have a couple more rashes that we see commonly in the outpatient clinic. But I did want to show you this slide that I found. This is really nice for trying to name rashes, which has been the bane of my existence. Naming rashes is hard. So I really liked this. And this came from, I think, Canada EM. I included the link down here. Yep, Canadium. So this is a really nice little branching tree to try to name a rash. Because I think that's hard for a lot of people, especially when you're not a dermatologist. So looking at, is it elevated, how big it is, the size will determine whether it's a macule or a patch. Is it solid? So if not, then is it filled with, what is it filled with? Is it pus? Again, what's the size? Is it a transient rash? So is it something that comes and goes? So like a wheal, what you typically will see with an allergic reaction or hives, that would be considered transient. And if it's not transient, so that's when we're looking at like nodules and papules and things like that. So we look at the depth, how superficial, how deep, how big. So it's just, I thought that this simplified it in a very nice way instead of looking at a bunch of definitions for the different terms. I really liked this.
Yeah, thank you for sharing this because I have so much hard time describing a rash in the clinic.
Mm-hmm.
This simplify a lot.
Oh yeah, that's been the bane of my existence. I'll tell my attending there's a rash and they'll ask me to describe it. I'm like, I know it's eczema. But okay. What do we think about this one?
Pustula.
What was that?
Pustula. No. It's no pus elevated and is vertical. Vertical.
So you're trying to describe it and you're doing a good job.
Yes, it's elevation. It
Yes.
It's no pus. And
So this
the size is less than 1 centimeter.
Mm-hmm.
So it is vertical.
Yes. So this is actually, I think this might be actually papular. So, because I don't think it's filled with a fluid. So this is Molluscum Contagiosum. This is a pox virus. We do see this. I've seen this a couple times, and they have this very typical appearance in this one in particular, where they have like a little dimple in the center, or an umbilication. These can take a little while to go away, but it's just a rash. The only complication with this is that you can be predisposed to a little bit of a bacterial infection, particularly if it gets scratched and is opened up to infection. But it's just a virus, and you will not see this on the palms or soles of the feet. So this one, you'd be elevated, and it's not transient, and it's solid. So you're going to go into the depth. It's going to be superficial, and they're probably less than 1 centimeter, so they should be papules. So this is kind of where you're going to fall. I think this is where you thought it was fluid filled in the picture. So I understand why you got to the vesicle. Okay. And how about this one? He looks like he's living the life.
It's include mercure and patch.
What do you think is causing this rash?
This rash,
Mm-hmm.
I think it's caused by infection.
Yes.
Maybe.
Yes. Do you know what type? If not, it's okay. It's okay.
It's a virus. I forgot a name.
That's okay.
Sorry.
That's okay. Don't apologize. So this is fifth disease, erythema infectiosum, caused by Parvo B19 virus. So this is a really typical appearance for this rash. It has that slapped cheek appearance, and that's where the rash will start, is on their cheeks, and then it will spread down to the trunk and their limbs that way. Again, since it's just a viral rash, it will go away. It'll run its course. But they do have a risk of having that aplastic anemia crisis with this type of rash. So that's always a good idea, just to make sure we're not having any other symptoms and it's resolving the way that it should. It's just going away. If it's persisting too long, or they're having worsening symptoms, that'd be a reason to see them back or have them seen in a hospital as well. But it will go away on its own. Okay. I think oops. Any idea what this is?
Scabies?
Yes.
Scabies, yeah.
Yes. So the scabies the females in particular will burrow under the skin. And so these red spots are kind of hard to differentiate. They could be viral, but when you see these tracking burrow marks, those really give it away that there's scabies going on here. And again, this is very contagious. I do see this in the outpatient clinic. And females can survive up to 2 days off of the human host. And so you can get transmission just from other items. Like if you're not cleaning your stethoscope or you're sharing a blanket, things like that. So you want to be very careful about sanitizing everything.
Make sure you guys wear your PPE when you go into patient room with scabies, because this is actually very contagious.
Yes. And a good rule of thumb is that if a baby has a rash or anyone has a rash, you should just put gloves on. Like, don't touch it without gloves, especially if you don't know what it is. Just put gloves on.
Absolutely.
Oops, I showed you this one. Oh, well. So I kind of gave it away anyways with the picture. So hand, foot, and mouth disease. And that's caused by Kawasaki A virus. Typically, the lesions on the bottoms of the feet and the hands will not be painful, but sometimes some strains will make it painful. So Kawasaki A6 can make those lesions painful, and they tend to have a little bit higher fevers and a longer duration. But again, this will just run its course and go away. And you may see the mouth lesions may be just around the mouth. They may be inside the mouth, inside the cheeks, on the tongue, on the roof of the mouth. But that's very, very typical for hand, foot, and mouth disease. I have seen a few of these.
In Vietnam, we see a lot of severe case of hand, foot, mouth disease. Mm-hmm. And it's also caused by EV71, mm-hmm. EV71 yep. virus. And it's make us it's called severe encephalitis, and oh, also wow. Also shock in children. Yeah.
Wow.
Very severe. Yeah. And most severe case is not typical dermatology manifestation like this, because some mechanism explain that EV71 have lymphophilic, so it's make encephalitis.
Mm-hmm. Yeah, that's definitely something we see for sure.
Yeah, enterovirus can cause a lot of things.
Yes, they can.
By the way, I think hand, foot, and mouth also affecting adult as well, right, Dr. Gooch?
Oh yeah, you can get it as an adult as well. It's definitely more common in kids though. Typically after you get it, you don't usually see it again. So it's not something we see a lot of like one kid with back-to-back hand, foot, and mouth infections. So, okay, I just have
because I saw one parent come in with the kid hand, foot, and mouth, and then next week I saw them again for their own hand, foot, and mouth disease. So,
mm-hmm.
So they get that from the kids.
I only have a couple more, and then because I think I've gone over time a little bit, so. I'm not sure. What
no, you're good. You can
Okay.
go up to 8.
Okay. So what do we think about this?
Maybe it's impetigo.
That's exactly what this is. And so this is a bacterial infection of the skin. This one does require treatment. This is also very contagious. Particularly when we have kids, it's really, really important to emphasize keeping our hands clean and not scratching it. And sometimes we get little spots of this all over the body. Sometimes it's just one location, like on the cheek. If it's on like a limb, I always recommend keeping like long sleeves on or long pants on. It just helps them stay away from it. Because they can scratch it and then they scratch another part of their body and just keep spreading the bacterial infection. I also wanted to include this because I've seen impetigo in a hairline with a scalp infection before, and it's not where you expect impetigo to be, but anywhere on the surface of the skin where you have a break in the skin, you can get this infection. And so topical mupirocin ointment is what we use for single locations or not very expansive infections. Like here, we would use the ointment, but if they had spots all over their body, we would usually just treat with Caflex or an oral antibiotic, just because it's hard to keep applying an ointment multiple times a day all over your body. So, but this is usually caused by Staph aureus. It can also be caused by group A strep as well. Any questions about this? Okay. How about this one?
Eczema.
Yes, eczema. And eczema is one of the bread and butter rashes that we see. We see lots of kids with eczema. Eczema in itself is not an infection. It's just an allergic type of rash. And so what happens is they lose more water and have just drier skin. But it does open up for the possibility of infection. So I have seen kids with eczema that also get impetigo in parts of their rash as well. So there can be multiple components to these rashes for sure. So for these kids, it's really important to avoid triggers. And a lot of common triggers are like harsh soaps or detergents, a lot of sweat left on the skin, things that have like fragrances in them. With kids in particular, bathing them too frequently. We usually don't recommend babies getting baths more than about 3 to 4 times a week, and just trying to wipe them down in between then. But keeping their skin hydrated is really the most important part. So you can use unscented lotions. Vaseline is really great. Aquaphor is just similar to Vaseline. It's pretty much the same thing. But they make really great barriers for the skin and help trap the moisture on the skin. So usually with a lot of eczema, we'll recommend like Vaseline or Aquaphor 4 to 5 times a day, like quite frequently. It's not going to hurt the skin. And then you have things like topical steroids. We do use topical steroids quite a lot, particularly with, like, if he had this type of eczema all over his body, we would definitely recommend a hydrocortisone cream. We don't typically recommend the topical steroid for use on the face or on the genital area because of the risk of thinning the skin. You can temporarily use it in those areas, but we usually don't recommend using it more than 2 weeks at a time and no more than 1 or 2 times a day. Just very restrictive on the skin or on the face or on the genitalia, just because it can cause like worsening rash, really, because you're thinning the skin and exposing it to infection too. So it's just not something we like to do if we can avoid it. And then what I also read is that you can use oral antihistamines to help with this too. We typically don't do this with kids, but it's something that might be considered for adults. Any questions on eczema?
Yes. Can you share how do you use tacrolimus calcineurin inhibitor?
Hang on one second. Because this is not one that I don't frequently use this for eczema, so I'm not sure if that's an adult only. Hang on.
I think it's most likely to be used in adults. I haven't seen this used in pediatric patients.
Yeah, I think that's why I'm not used to it. I would
don't.
Yeah, we don't recommend
Yeah.
this one usually for kids. So it sounds like it is an adult only because I've just not used it with eczema. So that's why I had to look it up real quick to see what it was.
Yeah, I think I never used tacrolimus for pediatric eczema. Even if in adult, I only use it if other therapy fail, like if my steroids fails, and I step up to the severe steroids, then it's fail. Then I start thinking about that one.
Yeah, so
because
typically
there's a stepwise approach.
Yeah, typically our treatment pattern is first we make sure that they're managing the triggers, so managing their soaps and detergents, not bathing too frequently. We talk about those kinds of changes first. Adding unscented lotions, Vaseline, and Eucerin. Those are really great ointments and things that you can get over the counter. If they're still having trouble and not having any improvement, then that's when we add the hydrocortisone cream typically, and that usually will clear most kids up. Some kids need a little more help than that, but there's different strengths of the steroid creams as well, and different options there as well. So usually that's how we kind of step up. We always make sure we talk about the basic things first, though, like making sure we're managing the soaps and detergents and not bathing too frequently. Those will just keep making eczema flare up no matter what you do. So, okay. So I did include this one last minute. So Kawasaki disease, that's one that I didn't think about when I was making this PowerPoint, and talking to Leon this morning, I decided to add it. This is one we do see particularly in the inpatient setting, but it's a good idea to recognize it it's good to be able to recognize it in the outpatient setting as well. So let's see here. Sorry, I have, okay, so there was the pictures of different types of rashes. Really with Kawasaki disease, you're looking for any sort of rash, but particularly the conjunctivitis, this red strawberry tongue, the lip rash. Kids usually are quite miserable when they have this. All these crying pictures are usually quite accurate. And then I brought up the diagnostic criteria for this as well, because you have the risk of like heart defects and issues with the heart with this too. So it's a good idea to know what this is so you can treat it. And aspirin, high dose aspirin is usually the go-to treatment for this. So these you have to, so to diagnose this, you're looking for a fever lasting at least 5 days without any other explanation, and then at least 4 out of 5 of these criteria. So the conjunctival injection, any sort of oral rash or blistering or fissuring, or the strawberry tongue, anything with a mouth. Extremity changes, so we're looking for rashes that can include the palms and soles of the feet. And then you get the polymorphous rash, just meaning that there's different appearances that it can look like. There's no real typical, like this is the description of a Kawasaki rash. Usually just any kind of rash will qualify for this. And then cervical lymphadenopathy. So that's typically what we're looking at for Kawasaki. So it's a good idea just to be aware of that as a possibility, really with any sort of infection with a rash, just to be aware of the diagnostic criteria, because that's something we do see on the inpatient side a decent amount. And then the other one that I didn't add a slide for that I wanted to include was MISC, which is multi-system inflammatory syndrome of children. And this is a side effect of COVID that we've seen with PEDS patients. So, and again, this rash does not have a super typical appearance. It can look like, so any sort of rash will work for this as well. But I did bring up the clinical diagnostic criteria for this as well. So there isn't really like a set criteria like the Kawasaki disease. It's just kind of, you're looking for certain association with symptoms. Usually they have lots of fevers. GI symptoms, rash and fevers, and a history of having COVID are usually the things that will all alarm us that MISC might be what we're dealing with. And so any sort of rash works for this. Again, you can have conjunctivitis. So this can mimic Kawasaki quite a lot. So a lot of the times we have these kids that are just fevering and fevering and fevering, and we don't know what's going on, and we can't decide if it's Kawasaki disease or MISC. And so that's kind of usually the diagnostic dilemma that we get stuck in with these kids. So some of the other things, though, that we are always looking for is the laboratory findings. So we do a pretty extensive workup when we do have MISC or suspicion for MISC. We do all these inflammatory markers because these do tend to be elevated in our kids with MISC. And we'll also do an EKG because there is a possibility of side effects with the heart as well. And so typically the treatment for this will be IVIG. And usually after one infusion of IVIG, everything settles out and they do really well and usually discharged a day or two later. So they do really great after it. But they will keep fevering and being miserable until we do something. It just does not, it's not a fun one to see kids with MISC just because they are just so miserable. They don't like, this does not feel good to have. But we have seen quite a lot of this as well. So those were the pictures that I had on my slides. I think Leon sent me some questions, unless anybody else has any burning questions.
If you have any question, please write it in the comment section, or you can speak up if you want.
Yeah, it seemed like throughout your presentation, some of the common questions were answers.
Okay.
So I'm just gonna, if no one have any question, or just feel free to type question in the chat. We're just gonna go through the question that people sent us like prior to the talk. So
there's a couple of things that I did want to emphasize because Leon, you sent me some chats in the chat that I thought were pretty good. So one of the questions you asked was, how do you distinguish if it's an infected or non-infected rash? This is really important, especially with our newborns, because there's so many skin findings with our newborns. Really, you're looking at the whole clinical picture, and I think that's something we emphasized throughout the talk, but you're looking for any sort of symptoms or side effects. So are we having any other like upper respiratory symptoms like coughing, congestion? Is there like localized swelling like with the impetigo? Do we have that thick crusting? Is it tender? If it's tender to the touch, that also tells us that it usually is more infectious. If they have fevers, obviously. So those are all really good keys. If we're just having a rash that doesn't really hurt and it's just kind of there and it's going away and they're not having any other symptoms, it's not usually something that we're too worried about. It's usually something that we can manage on the outpatient side. And I see
hand raised. Yeah, that's right. Actually, Thuy have a hand questions.
Yes.
Yes, I have a case after the baby get the vaccine, and there appear this how can I say the spring?
I think in that case, maybe send us an email about the case, so we can answer it better that way. Because sometimes when you mention the case on the talk, it's kind of get prolonged and we kind of miss information in between. So I'll have you send me an email on the case.
It's okay, but I just get that case to this, and in past I get some case let us the baby after get the vaccination, the rash appear the side of the soft.
So
and, yeah, but I don't know what that.
So you're saying there's a rash after they were vaccinated?
Yeah.
And how old?
Maybe about 6 months.
I think you're breaking up. I'm having a hard time hearing.
This is 6 months.
Oh, 6 months. Yeah, so It's not always an uncommon finding to have a bit of a rash. It's hard to know without actually being able to see it and to see the child. But as we know, the vaccines can really stimulate your immune response. And it's also possible that there could be a concurrent viral infection. We see rashes with viral infections very, very frequently. So usually if they have some kind of viral infection that they're handling just fine, they're eating and drinking okay, they're not having trouble breathing, they're not having any other severe side effects that would make us want to admit them or be worried about something like Kawasaki disease or MISC. Typically we can just chalk it up as a viral exanthem or a viral rash, because almost every virus that we get can cause some kind of post-viral rash. So that's always a possibility that they have a viral infection and coincidentally also had vaccination. But really anything that causes an immune response can cause a rash as well. So.
No, because right after, only about maybe 30 seconds, right after they get the result.
That could be an allergic reaction then to a component of the vaccine. Was there any?
I think usually when we vaccinate kids, we usually watch them for about 30 minutes or so.
Mm-hmm. So sometimes we do get a little bit of an allergic reaction to a component in the vaccine. Some vaccines use different preservatives. And if there's if it's just a rash, that is a reasonable reaction still. If there's any sort of threat to the airway swelling, shortness of breath, anything like that, that would be, of course, concerning for an anaphylactic reaction and would be a contraindication for them to have vaccines in the future. But if they just had a rash and no other real symptoms, that's not always abnormal, and that's a rash that is okay. So we get kids that will sometimes get a rash after having amoxicillin, and we will still give amoxicillin. That's not an exclusionary factor for getting that in the future, because rashes just are not. It's not uncommon. It's not a life-threatening complication. It's just something that can happen. But I would think that if it happened immediately after the vaccine like that, that it was an allergic reaction to something in that vaccine. That would be my guess. Usually some Benadryl will take care of that.
Every other normal. It don't seem the reaction from the
Leon, were you able to hear her? It's kind of broken up.
I kind of lost at the end, but I think she also says normal sometimes.
Mm-hmm.
Thank you, Dr. Thuy, for the great case.
Yeah, thank you. That's definitely a good point to bring up. Anytime you get a rash after having a vaccine or medicine, I would always go with trying some Benadryl. But with our current environment and families always being a little bit tentative now of vaccines, I try to encourage whenever I can, when it's okay for them to continue getting vaccinated. I definitely don't like to try to discourage vaccination in any way. But sometimes alternative vaccines need to be considered just because of allergic reactions to components.
So thank you. Our time is up, but I have one quick question that I think that most people will want to know the answer.
Yeah.
Is what is the first thing that we should tell the parents when they discover their child having a rash?
Right. So
I think as doctor, the most of what we do is reassuring, but I also want to hear your opinions.
Right. Yeah. So whenever I have a new mom or anyone coming in with a new rash, it's always important to get a really thorough history before you decide what it is. And that also just makes the family know that they're listened to. That's a really important part of this, is making sure you're building a good rapport with your patients, because you want them to trust you when you tell them what is going on. If you don't build a good rapport and make them feel like they're being listened to and acknowledged, that's when they're more likely to disagree, and they're going to keep going to try to find help for this, and They'll go to the ER and get all this medical care that they don't necessarily need. So it's really important to make sure that they know they're listened to and you're getting a good history. Know how long it's been going on. If there's any other symptoms, any fevers, get the whole clinical picture, do a really good exam, and talk about what their concerns are. If it's just looking like it's an allergic reaction or eczema, something like that, there's a lot of over-the-counter things that they can do for comfort and to make it go away and to help it just improve with symptoms. A lot of the times what we get is concerned families with new rashes is it's usually a viral rash, because it's a rash they've never had before and they've never had issues with rashes before. And so it's a new scary thing, but they've also had a recent viral illness. And so we're able to just explain, yeah, sometimes this happens. Lots of viruses cause rashes, but your kid is completely fine and you can go home and everything will just go away over time. It just might take a little while. So it's really important really to build rapport with that family, make sure they're listened to, get a thorough history, don't just dismiss them. If they are having other symptoms, make sure, if we are concerned about Kawasaki disease or like an MISC picture where these are some more severe rashes, that they are getting the appropriate care and treatments that they need for that too.
Correct answers. So bottom line is do not dismiss parents' concerns. Just acknowledge it. Full physical and history is important. And go from there.
Even with my toughest families, with the most intense parents, if you just acknowledge their concerns and address each of their concerns, they will settle down and they will trust you.
I absolutely agree. I think working with patients from all walks of life and very diverse, from adults to pediatric and parents, the bottom line, the common theme is that patients just want to be listened to. And if we give them the opportunity to share their concerns and their worries and just tell their story, just get it all out of them. You just sit there and listen and ask open-ended questions, give them a chance to share everything they have in mind. And then after that, they become very receptive and they trust you. And if they trust you, then everything just becomes easier, much easier after they trust you. Thank you so much for a great lecture today. And I think it's very fun that the way you made it, very interactive. And I think our participants love it as well.
I really appreciate everyone that participated. Thank you so much.
Yes. Everybody, if you can send some love to Dr. Samantha Gooch, give her some hearts. If you appreciate her, show her your appreciation. That would be wonderful. And we'll have a survey evaluation form for you to fill out. After you fill out this form, we can send you a certificate of completion for today's session. And we'll see you again in a month. We will have our monthly seminar on the second Sunday of every month. So please put that on your calendar if you enjoy this type of discussion seminar. And we will try to create even more opportunities for you to update information, update knowledge, and practice medical English as well. This is an opportunity for us to learn from each other, and I learned some new things today as well, some review as well, so that was really good. Thank you for everybody participation today. I will see you again in 1 month. Goodbye.